Now. Okay, so I would like to welcome everybody to the Resident and Family Support Council that we have on the second and the fourth Tuesday of every month. These meetings are really, we have these meetings to make sure that we inform people and we empower people with information so that they can navigate this long-term care world in a much better manner for themselves. So we can get with that, what we need, what we want, and what we deserve when we're navigating this path that can be extremely complicated. Through these meetings, we do record them. And so they are always placed onto our YouTube channel. And if you haven't had a chance yet, please check them out. There's over 30 videos on there, and it's a variety of different topics. And I'm sure you'll find some topics there that could really be helpful for you. Like today's topic, one of our most frequently viewed topics in the past has always been when Illinois Department of Public Health has joined us for these meetings, because it's really empowering to know exactly what is going on in this world in regards to COVID. And so we've invited the infection prevention team from the Illinois Department of Public Health to join us to talk about this and to help answer any questions that anyone may have as well. I know there's a lot of questions buzzing out there in regards to boosters, and also the flu's happening, and there's all sorts of other things that are going on, and it can get extremely confusing for everybody. So what I'd like to do right now is I will introduce Dr. Counard, and then we also have Mike Bierman, who is joining us as well. And I'm going to go ahead and I'll pass it off to both of you.
Thank you. Thank you very much, Lee. This is Dr. Catherine Counard. I'm the State Medical Officer in the Office of Disease Control at the Illinois Department of Public Health. I've spoken with you a couple of times in the past on this topic, primarily COVID-19, but I have been the medical lead for the COVID-19 response in long-term care facilities. So I'm always happy to meet with the Ombudsman and the Family Council to share what's new and also hear any questions or concerns that you might have. And I actually have with me Mike Bierman, who is an infection preventionist with IDPH, who's covering the southern half of the state. So some of you may have had an opportunity to interact with Mike in the past. So I think because we both have presentations, I will go ahead and let me see where my share is on here. Oh, here we are. Okay, let me get my presentation up. And I have so many things open, I cannot find it. My apologies. Let me close a couple of things here. You know how that goes. Oh my gosh. So 1 second here while I close some of these open.
No problem.
I can find my presentation buried under here. I was just presenting to somebody else. So break away to come here. All right.
Thank you for that.
Oh, sure. Okay, let me get to the first slide. All right. Okay, good. So here we go. Share. Let me try sharing this. We can do it. Okay. Do you see the title slide?
Yes, we do. We're all good.
Okay, great. Fantastic.
I also see your presenter notes, just in case. I don't know if you wanted to share those or not.
Okay, it doesn't really matter, but
no, yeah.
Let me see here. I haven't presented on Zoom in a minute. Let's see if we can. Oh well, doesn't matter. Give you a little, as long as you can see the first slide. That's all that really matters.
Yeah.
For some reason, it's not doing that. Okay, so anyway, here we go. I'm going to just tell you a little bit about some of the current COVID-19 data, and I'll hurry along here so Mike has plenty of time for his piece. I'm going to go over just data, vaccinations, therapies, and then Mike's going to give you the overview of the most recent long-term care updates from CDC. So that's how we're planning to divide up for infection prevention and control. So I just, there's a lot of data. There's links in the slides. I will send the slides to Lee to share after this meeting, but how many vaccines administered, more than 25 million vaccines. Unfortunately, we've had almost 4 million cases and 35,000 deaths from COVID, but there's a lot of information also, including what variants are circulating in the state. And then I just wanted to take a quick look at age demographics. This is from a few weeks ago. I didn't have a chance to update it today, but really the pattern hasn't changed. And you can see here, the colors are by race. And we all know that there's a disproportionate impact on persons of color, but just in general, 20-year-olds and under are over on the left here under cases. That's where the vast majority of cases are occurring. Whereas the older group, 60 and older, is to the right of this cases on the left side of the screen here. You can see the older group is much less, but if you look 80 plus, that's the lowest number of cases. However, when you look at deaths, that's primarily the age group is that 60 and older. 50 and older really is the age that is experience the most severe illness and death from COVID-19, even until now. And those are primarily the individuals that are in our long-term care facilities. So I wanted to show you, we have data going back to the beginning of the pandemic where you can look at cases, and long-term care cases are 3% or so of all cases in Illinois. So if you can imagine this is 3%. The number of cases is huge in comparison. So, but this is the group that has the highest risk from COVID-19. Let me just take a sip of water here. Our priorities, as they have been throughout the pandemic, is to make sure that the residents in long-term care are up to date on their vaccinations, that the facilities are providing infection prevention and control, which Mike's going to speak about, and that important for you all as ombudsman and also for family members to make sure that if your loved one who's in a long-term care facility contracts COVID-19, despite our best efforts, that they get treated, because the therapies for COVID-19 are life-saving. This is deaths. Unfortunately, we are still continuing to see deaths from July through October of this year. Approximately 42 long-term care resident hospitalizations and 22 deaths per week. And it's kind of flat looking, I mean, there's a little bit of variation week to week, but we're doing much better, clearly, than we were previously. But, until we can say that we've done everything possible, that all of the residents were boosted, they're up to date on their vaccinations, and all of the residents that got symptoms that had COVID were treated. And, I don't think we're going to be able to rest on any of this. I just wanted to share this slide to show you, this is from our annual report, but it was from July of 2021 to August of 2022. How much work IDPH has put into preventing severe illness and deaths from COVID-19 in long-term care facilities. We've had a team of very talented infection preventionists, including Mike, who performed during that year 3,656 consultations on infection prevention and control. Every week, we were having long-term care webinars across the state on COVID-19, typically with 650 attendees in every one of them, to go over what the guidance was, to answer questions, to make sure that everyone was doing everything possible to protect residents. We also were working with our sister state agencies that operate 24/7 facilities, including the VA and Department of Human Services, which operates mental health psychiatric hospitals, as well as state-operated developmental centers. And then we have our corrections. We, over that year, updated guidelines and educational materials 11 times. As the science changed, as the knowledge improved, guidance was changed, and you've all lived through that, the different variations of guidance. And then I'm very pleased to say, work with our Office of Healthcare Regulation, Legal, and our rules team to strengthen the skilled nursing facility permanent infection prevention rules as of April 2022. Previously, the long-term care facilities, skilled nursing facilities had to have someone designated as an infection preventionist. But it didn't spell out what that training was the person should have, and we all know an infection preventionist, they are skilled, have specific training. And we've been blessed during this pandemic to have some of the best infection preventionists in the nation working with us, that they lived in Illinois, 40 years, decades of experience to help us guide through this terrible pandemic we've been experiencing. And so unfortunately, many skilled nursing facilities just said, well, the director of nursing can add that to all of her other duties. And it wasn't getting the attention it needed. So now these permanent rules spell out how many hours have to be dedicated to infection prevention and what kind of training and experience those individuals need to have to work as an infection preventionist in a long-term care facility. We also strengthened that there's now a requirement that all the staff have to be trained, including students, including interns, before they ever walk out onto that floor and provide care to your loved ones. They now have to have had training, and that has to be given annually. And so on. We specify what training and how, also that they have to comply with all of the public health requirements and recommendations for not only COVID, but flu and other infectious diseases in facilities. So I think this is a major step forward that we were able to get these permanent infection prevention rules passed. I also want to mention that IDPH Illinois was recognized for all of that hard work. If we go back and look at the slides, all the work we did to decrease the terrible toll COVID was taking in long-term care, vaccinations, infection prevention and control, and therapeutics to dramatically reduce the risk of death for our residents, our most vulnerable residents in Illinois. We just kept going. And so we were recognized with an article that compared the risk of death between those 65 and older in long-term care facilities and those living in the community. And we substantially narrowed that gap. So this is just to encourage you all to stay up to date on your vaccinations, including flu. I did not put in anything about flu shots on this because of the time limitations, but it's really important, especially for older individuals, meaning 50 and older, to stay up to date with COVID-19 vaccinations. It's important for everyone. And there's sometimes confusion about what does up to date mean. And this is all from the CDC website, but once you have gotten your initial vaccinations, what it is based on your age, the vaccine you first received, and the length of time since your last dose. And that's all. There's some nice charts, and I have them in here to tell you how do you know if you're up to date with vaccinations. And then people who are moderately or severely immunocompromised can have a slightly less of a robust response to the vaccinations. And so they have somewhat different recommendations for what it means to be up to date. But as long as you have received the vaccine that you should have received. So for instance, you just received your first dose. Now you're considered up to date until it's time for you to get your second dose. And then there's some questions about what does it mean to have a bivalent booster? And the updated bivalent boosters are called bivalent because they protect against both the original virus that causes COVID-19 and the Omicron variant, BA4, BA5, that we've been experiencing most recently. Previous boosters were called monovalent because they were designed to protect against that original virus that first made an appearance. And they did provide some protection against Omicron, but not as much as these boosters that were specifically designed to target Omicron. So that's why this vaccine has both. The virus that causes COVID-19 has changed over time, as you know. and different versions of the virus have developed that are called variants. You can go to the CDC website to learn more about the variants of the COVID-19 virus. I'll put that link in. Sorry, Lee, I missed it here for this slide. And then both Pfizer and Moderna have developed updated bivalent COVID-19 boosters, and all of our long-term care residents, with very few exceptions, have either gotten Pfizer or Moderna. So for adults, all adults were recommended to receive one bivalent mRNA booster dose. That would either be the Pfizer or Moderna after completion of any FDA approved or FDA authorized primary series, or previously, if they previously received monovalent booster doses. So for someone like me, I got the first 2 doses of vaccine, and then I got the 2 booster doses that were recommended after that, in the fall of 2021 and the spring of 2022. I, of course, got my booster doses, but then, and now I've had the bivalent booster. So I would be up to date, even though now that would be my fifth COVID-19 vaccination. You can't get the bivalent booster. It's not approved to be a primary series. So you still have to get the primary series done, and then you can get the bivalent booster. And those monovalent vaccines that are the primary series are not authorized as a booster dose. So I just want to share just a couple of slides with some of the common questions we get that are from the CDC, from a meeting that they had from the Advisory Committee on Immunization Practices. Anybody can go look at the recordings, listen to how decisions are made about vaccinations. You can even attend these presentations remotely. I've included here a link to this particular ACIP presentation, but you can go to the ACIP website, and they have meeting materials going all the way back to the 1960s, from when they first were formed to start making vaccine recommendations. So this is for people who are not immunocompromised, whether you've gotten a Moderna, a Novavax, or a Pfizer vaccine as your primary dose. People ages 12 and older. There's some determination depending on which of these vaccines you're getting, whether it's 3 to 8 weeks or 4 to 8 weeks between the 2 doses. But then 2 months after, regardless of which primary series you did, 2 months later, get your bivalent booster. And then Janssen, we're not really recommending the use of Janssen, but there was 1 dose. So for people ages 18 and older, it was not approved for kids. Then they should get a bivalent booster at least 2 months later. And it should be a bivalent, not Janssen or J&J. The only difference here with the people who are moderately or severely immunocompromised, because they don't mount as strong of a response typically to the vaccine, we do recommend that they get an extra dose. So that's why you'll see here, for instance, that they receive this extra dose and then they get the bivalent booster. Same thing here with Janssen. They get an additional mRNA that's just considered an extra dose, and then they get the booster. For timing, for people who've had COVID-19 infection, SARS-CoV-2 infection, for sure, if a person has just gotten over it, you should not give a booster dose if someone is currently ill with COVID, obviously. But even if you've been exposed, if you don't have COVID, you could get your booster. But then CDC has said you could consider delaying up to 3 months or 90 days after your SARS-CoV-2 infection to get your bivalent booster vaccine. And the thought is that it may give you some additional protection, but that is just a may consider. That doesn't mean you absolutely have to. So for instance, if there was an outbreak in a facility and it's now 2 months later and the pharmacy is coming and it's not easy to get a pharmacy in there to get the boosters, then you should have your loved one get vaccinated at that time. There's no harm in it. There's some thought that if you wait the full 3 months, you may have an even greater boost, but it's just a few percentage points. So it's not, it would be better to go ahead and just get them vaccinated. And that's kind of taken into, again, these are slides from ACIP where they say, you know, there are other things that you should take into consideration to when determining whether to delay getting a COVID-19 vaccine after infection. Co-administration of COVID-19 vaccines with other vaccines. You can give the COVID-19 vaccines with all age appropriate vaccinations. So anything for which a person is eligible for at the same visit, that should be administered. The only consideration would be people, which is unlikely to be anyone who we're speaking with today, but if there's anyone who's needing to get a vaccination for monkeypox, that might be something that you would have to, especially young men, they should consider speaking with their provider about possibly not having those two at the same time. But other than that, for instance, flu vaccine, it's important. Right now we're in flu season, so please go ahead and get your flu vaccinations to protect your loved ones. And it's important for prevention of severe disease, hospitalization, and death. We used to worry about flu as the main respiratory illness in long-term care facilities before COVID. But and both of those vaccinations can be given at the same visit. So if you're due for your booster, bivalent booster of COVID and flu, please get them both on the same day. There's no reason not to. And if the pharmacist is coming to your loved one's facility, they can get both of them on the same day as well. And here's some resources for you. I don't know, some of you may have family members who are reluctant to get vaccinated. CDC, HHS, both have really great materials that can help you persuade individuals of the importance of getting vaccinated. So I'm going to hurry along here because I do want Mike to get through his materials. I won't take much time here. This is Mike's piece. I do want to just mention that all of these are important measures: masking, cleaning, hand washing, getting vaccinated, isolation and quarantine, staying home when you're sick, testing to see if you have COVID-19. Those are all part of our armamentarium in order to prevent the introduction of the virus into a facility and the spread within a facility. And it is clearly shown in our data that the more disease that's circulating in the community, the more likely it is to come into a facility, and then it can spread. Very quick word about treatment. People with underlying health conditions are more likely to get sick with COVID, even if you've been vaccinated, and these treatments are available. They can be life-saving. So please don't delay for yourself or anyone of your loved ones who are in a long-term care facility with getting them treated within days of when the symptoms first develop. If a person truly does not have symptoms, that's one thing, but anything, sniffles, the idea is, I mean, there's a misperception out there that you should wait until their symptoms get worse. Otherwise, why would you get treatment? But the trouble is, if you wait till the symptoms get worse, then it might be too late and they may end up in the hospital anyway. These medications are very effective. And right now we just have the oral agents for treatment, but because the bebtelovimab monoclonal antibody that was available is no longer found to be effective against the current strain variants that are circulating, but these oral agents are widely accessible and they do work against variants. There's a list here. You'd be surprised. I have a couple of them on a slide, but it's a very extensive list of higher risk medical conditions. So what are oral antivirals? They're pills that stop the virus that causes COVID-19 from making copies of itself in your body. And when do you have to use them? Within 5 days of when your symptoms first appear. They're taken at home 2 times a day for 5 days. Who's eligible? For adults, The two options are Paxlovid and Lagredo. It's also known as molnupiravir. Paxlovid, you might have heard of in the news. It does have some interactions with other medications. Molnupiravir or Lagredo does not have any known drug interactions. So it's not quite as effective as Paxlovid. Paxlovid is 95% effective in preventing hospitalization or severe illness and death. But it's better than not giving anything. And so if your loved one is on a medication that might have a severe interaction with Paxlovid, please advocate for them to get this other medication as an alternative. So who's at high risk? Primary risk is age over 50 years. If you're immunocompromised or have a weakened immune system, underlying health conditions, this is just a few of them: obesity, cancer, chronic lung, liver, and kidney disease, mental health conditions, disabilities. The list is quite extensive, and I would encourage you, you might be surprised to see how many things are on that list. And then I think this is my last slide before I quick hand it over to Mike. He's going to have to speed walk through his slides. Steroids and antibiotics don't have any place in the treatment of COVID-19 as an outpatient in a long-term care facility. They can cause harm and they don't provide any benefit. The individual has a viral infection. Antibiotics are for bacterial infections. And so since they don't have a bacterial infection, an antibiotic would not be recommended. And the same thing, steroids have in fact been potentially shown to cause it to COVID-19 to become worse. So sometimes people get into the habit of just giving a Z-Pak and a steroid for someone who has a respiratory illness, but not for COVID-19. So just to have that in the back of your mind when you're speaking with the providers that are taking care of your loved ones. And that's all that I have. Mike, can I turn it over to you?
Thank you so much, Dr. Counard. Yes, and what great information. And Mike, we're really looking forward to hear what you have to say as well. You can feel free to share your slides yourself.
Okay, thank you. Let me see if I can get these pulled up properly. Give me one moment here.
And while you're doing that, Mike, I'll just let everybody know that our person who works the magic behind the scenes, Stephen Maxwell, has taken a lot of those website addresses that you shared, Dr. Counard, and he placed them into the chat.
Oh, thanks for doing that.
Yeah, he's great.
I only got the one with the coronavirus variants. I didn't get the rest of them.
Okay, great. Still, thank you, Stephen. We appreciate that. Okay, Mike, are you getting it? There we go. It's starting to share. Okay, we can see your slides.
All right, let me. Okay, how's that look? That look okay?
It looks perfect. Thank you.
All right, excellent. Thank you very much. As Dr. Counard said, my name is Mike Bierman. I'm an infection prevention consultant with IDPH. I've been a nurse for a little over 27 years. I've done infection prevention for 18 of those years. So I do work mostly in the southern part of the state, but I also assist with some of our Department of Corrections and other areas as well. So I appreciate you having me here today and allowing me to speak. The piece that I'm going to cover is kind of going over our guidance for long-term care facilities for COVID. I think Dr. Counard mentioned earlier, there's, as we've gone along, there's been different iterations of the guidance as we've learned more information. The science has advanced, so does the guidance that we present to the for the facilities. The Illinois Department of Public Health's most recent update to the guidance came in early November. So what I'm going to focus on here is mostly some of those the updated information, kind of give a comparison to what what facilities were doing prior to, so that you have an idea when you go into a facility, why they're doing certain things and implementing certain measures during certain times and different levels of COVID activity in the area. So go ahead and get started. The first slide I have here, obviously you can see there's a couple of different maps of Illinois, and I wanted this for kind of a twofold purpose. First, you can see there's been an increase in COVID activity throughout the state. We've seen that over the last few weeks, kind of taking that uptick and seeing more and more COVID cases throughout the state, like I said, over the last few weeks. But also to kind of show you the difference as to what long-term care facilities are looking at and utilizing to help guide them in what measures they're implementing versus what community are using when they're looking at these numbers. And this map on the left here is COVID-19 community levels in Illinois. And that's kind of the map the community, obviously the community would use. It's kind of, I guess you would say maybe, Joe Public would use to guide them on if masking is needed in public areas and different measures that they might take on a personal level to help protect themselves. And you can see at the bottom part of the map there's a key, and we have low, medium, and high. And on the map, it's pretty even distribution of where we're at right now with where some of these counties within the state fall on that range. But if you look at the map to the right, this is the map that long-term care facilities are utilizing to guide them. And again, this is called community transmission. And you can see at the bottom of the map there's high, substantial, moderate, and low. But obviously, almost the entire state is in that red and that high range right now. We have a couple of counties that are still in the substantial, but overall, almost all are in that high range. And these are the numbers that facilities are looking at to help them make decisions. And I just want to make that differentiation because I think sometimes, people may go, out into the public or other areas in the community, not see, a lot of any type of measures being implemented, and then they go into a long-term care facility and notice that they're still masking and they're still using some more stringent measures there, and this would be why, because this is the information that they're utilizing to help drive their efforts then. So when we look at that, we're asking long-term care facilities to monitor this community transmission, not the community level, but the community transmission, that second all red map. And we want them to look at that on a weekly basis. Best option we've told them is, look at that every Monday. And that's going to help them, again, like I said, decide if they need to increase some of their prevention measures. So when they look at that on Monday, if they've been running along for several weeks in moderate or substantial, and then they check it on a Monday and it's elevated to high, we ask them to go ahead and immediately implement those more stringent infection prevention measures at that time. And then to continue weekly monitoring. And if they see that level then decrease again, then we want them to go ahead and if it decreases back to a substantial or a moderate, go ahead and monitor that. Keep those more stringent measures in place. Go ahead and continue to monitor that until they've reached a couple of weeks before they start to relax those measures again. So we want to be quick to jump on if the numbers have elevated, but if they're starting to decrease, we want to make sure that we kind of wait those couple of weeks before we start to relax those measures in those facilities. And when the facilities are looking at the community transmission, they've narrowed it down for their purposes of deciding on their infection prevention and control measures to basically two categories. Now, again, when we looked at that map earlier, we had high, substantial, moderate, and low. But they've grouped that substantial, moderate, and low into one category that they now call not high. And then we have the other, obviously, as just high, those areas in red. So when they're looking at it, they're going to look at whether they're in high And if they're in any of those other levels, then they're considered not high. And that's how the guidance then spells out for them, what types of things they may need to implement in those instances. So now we'll kind of get into some of those differences with the most recent guidance. And right off the bat, first thing is, screening for visitors and healthcare personnel, their staff. So, as you know, before, I'm sure most of you have been in facilities, and they either had somebody at the front door to, symptom screen, or they may have an automated system, or some places simply would have a paper questionnaire asking about signs and symptoms, any potential exposures, and so on. And that type of active screening is no longer required for the visitors and the staff. Now, you may still see some facilities still keep, instituting this at this point in time, especially as we're seeing cases go up, but it's not a requirement. And if they choose not to utilize that active screening, then they do need to implement a process to inform the staff and residents and visitors, of all recommended actions that they can take. Example, to make sure that they're alerting the facility if they have any signs and symptoms, when they need to wear masks, when and how to perform hand hygiene. And they can do this, simply by creating signs, posters, educational materials that can be posted at the entrance and in other places throughout the facility. Okay, and then vaccination status, and you can see we made this slide with very large bold lettering, and the reason being is I don't want this to be confused and give the impression that vaccination isn't as important as it had been. As Dr. Counard presented very well, using the vaccinations to help prevent and or lessen the effects of COVID are still one of the best tools we have in our tool belt, for this. But in past iterations of guidance, there were several things in guidance that were tied to an individual's vaccination status. Whether they were going to use indoor masking or quarantine some individuals, or some routine testing was tied to what someone's vaccination status was. That is no longer the case. They have taken that piece out, and someone's vaccination status no longer makes any of these determinations throughout the guidance. So source control or masking, using universal indoor masking for facilities. So again, going back to that community transmission, that they're going to look at those maps to decide what their county, what their community is currently in. If their community transmission is in high for wherever that facility is located, then they do recommend masking for everyone in the facility, in any areas where they could encounter residents. Staff may choose not to wear a mask when they're in well-defined areas that are restricted from patient access. So if they have break rooms, lounges, meeting rooms, these type of things, they may choose to not require masks in those areas. And when the community transmission is not high, so again, those other three areas, substantial, moderate, and low, if it falls in any of those not high areas, then facilities can choose not to require universal indoor masking. As with everything, there's always certain exceptions to the rule. I won't get too far into those, but if an individual has had an exposure, things like this may all still require masking in facilities. But as far as universal masking, a facility may opt to no longer require that when they're in that not high category. So again, just a kind of a look here for when that community transmission level is high. They're going to wear masks throughout the facility, with exception of those meeting rooms, lounges where residents wouldn't be encountered. And then they're also going to wear a mask and then add eye protection for any resident care that's being provided. So walking down the hallway, need to make sure that they have their masks on in those instances. If they're actually providing any type of direct care for a resident, then they're going to include a set of some type of eye protection to go along with their mask. All right, so new admissions. And again, this was one of those things that some of this used to be tied to a new resident's vaccination status. That's no longer the case. And so quarantine is no longer required, regardless of a new admission's vaccination status. However, testing might be required depending on, again, that community transmission level. So they're going to look at that map, and again, if they're in that high, in that red for their county, then they are going to need to test those new admissions coming into the facility. What they would do is they would test on day of admission, and then they would test on day 2 and again on day 4. And as long as they remain asymptomatic and none of those tests come back positive, quarantine would not be required for them in that instance then. If the community transmission is not high in their county, then they would not be required to perform this testing. Again, it would be at the discretion of the facility. If they chose to, they still could. And if they did, then they would still follow that same cadence of day of admission, day 2 and day 4 in doing so. Okay, and then managing resident close contacts. So what we're referring to here is a resident who's had an exposure to someone who is positive for COVID-19. And again, we go back to that, vaccination status does not play into the determination. Quarantine is not going to be required in accordance to their vaccination status. So as long as they remain asymptomatic and their testing remains negative, then they would not be required to be placed in quarantine or isolation. Now, these next couple of pieces, they're kind of tricky to articulate, so I just want to kind of go through it. It talks about they're required to test unless within 30 days of a COVID-19 infection. So if you have someone who's had an exposure and they've just recently recovered from active infection with COVID-19, maybe 15 days ago, then they would not fall in that area of needing to be tested. If they fall outside of that 30 days, then they would be tested with a series of 3 viral tests. And this is the part I want to make sure I explain well. When someone has an exposure, we consider that day 0 when we're counting up these things. And we don't want to test them on day 0 because there's a very good chance that if they've just had the exposure, they've not had time to where that test is going to show as a positive regardless. So we don't test on that day of exposure. We would test on day 1, the following day, and then on day 3, and again on day 5. So again, as long as they remain asymptomatic and none of these tests come back positive, they would not need to be placed into quarantine during that period. And then that last bullet point on this slide talks about, for those who have recovered from COVID-19 in the prior 31 to 90 days, that an antigen test or a rapid test instead of a PCR is recommended. And those PCR tests, those are the tests that the facility will collect, but then they get sent out to their lab to be performed and be processed. And the reason for this is someone who's recovered in the past 31 to 90 days, those PCR tests are very sensitive and they may still show positive due to that prior infection. These rapid tests are a little less sensitive in that manner, and so they have less chance of showing as a positive due to a prior infection. So again, just kind of in a nutshell, if it's been within 30 days, they wouldn't need to be tested. If it's been within 31 to 90 days, they would be tested, but your best option would be to test with one of the rapid tests. And then anything beyond 90 days of a prior infection, you would still be able to use those PCR tests as an option then. So, all right. Quarantine for residents following a close contact may be considered when, and I know what some of you might be thinking. You just told us on the slide before that quarantine wasn't required, for someone who's had an exposure, and that is true. But there's always those shades of gray, those gray areas where this may be considered for use still. The first bullet point there, if a resident's unable to be tested, or if they're unable to wear a mask as recommended for 10 days following the exposure, then they may want to consider using quarantine in those instances. A resident who's moderately or severely immune compromised, a resident residing on a unit with others who are moderately severely immune compromised, or a resident who resides on a wing or a hall or a unit that's having ongoing transmission, that they're having difficulties, preventing further transmission. These are all areas where they could still consider instituting quarantine for those residents. And then outbreak testing. The big difference here is the contact tracing approach at the top there. This is something newly added as an approach in the IDPH guidance. And what this is if they have a resident who has become positive, a resident or staff member who's become positive, the facility can do an investigation, identify anyone who's been a close contact to that individual, and then focus their testing on those people. We'd use that series of 3 tests, day 1, day 3, day 5, as we talked about earlier. And the big thing here is after that investigation and those initial tests, if none of those come back positive, then no further testing is required of them at that point in time. Now, in the instance that they would have additional cases identified, then they would want to expand their testing and go into more of this broad-based approach then. And this is very familiar to the facilities. This is what they've been doing for quite some time. They can focus it on a particular unit if all of the cases are occurring there, but if it seems to be more widespread, then they can encompass the entire facility. And again, they would do that testing every 3 to 7 days until they've had no new positives for a time period of 14 days. So again, this is something that facilities are very familiar with. This is what they've done for quite some time. And again, just a couple of notes there. No need to test if they've recovered in the prior 30 days. If it's been 31 to 90 days, then using a rapid test is your best bet there. And then also, if a facility is unable to perform that contact tracing, with confidence, then it might also be best to go ahead and go into that broad-based approach just to make sure that no one's missed in those instances. All right, a dedicated COVID-19 unit is no longer required. Again, there's a little caveat there, unless the number of positive residents would warrant such a unit. So again, facilities will have to, they'll look at this on a case-by-case, situation-by-situation basis. If they just have a few cases and they can safely manage those, in the general population or on the wings that they originally come from, then those would be able to remain in those areas. As you know, in the past, we started with facilities had to have a dedicated unit. Where they would dedicate an entire hall. Some places would dedicate, the back end of a hall, put up a temporary barrier to designate that. Then we moved into still having an area designated, but no separation barriers placed in the hallways. So now we've kind of moved into if it's just a few cases and they can manage them, on the hallways that they're on, then that is acceptable. But what they do need to remember is that, the resident still needs to be placed, ideally in a single room, and they need to have the appropriate isolation signage outside the room, and staff should all wear the appropriate personal protective equipment when they're entering those rooms. All right, routine testing for healthcare personnel. So for the staff, again, in the past, staff members who weren't vaccinated or who weren't up to date with their vaccines would require some type of routine testing, maybe once a week or twice a week. They would be required to be tested. That type of serial testing is no longer required by the facilities. Some facilities might, it's their discretion. They might still, decide to continue to do so. And again, we just refer them to the guidance if that's the case, because the main thing is they're not going to base that on their staff's vaccination any longer. They'll need to decide what metrics they want to use to decide who would be in that serial testing. But this is not something that is required of the facilities at this point. And then managing staff with COVID-19 or following a high-risk exposure. And again, this kind of goes back to the same as what we talked about with residents earlier. In general, if a staff member has an exposure, they remain asymptomatic and their tests are negative, then they can continue to work. They won't have a work restriction. If they test positive for COVID, then the best option is for them to be off for that 10-day period. But there are contingency and crisis staffing modes. I'm not going to go deep into those at this point in time, but there are those options that staff can, or that facilities can follow in order to be able to maybe bring staff back sooner if they're getting into a situation where they have several staff out and they have concerns on being able to provide adequate and safe care for the residents. A few other changes in the guidance. One, physical distancing is not overly emphasized. They do still talk about it when they discuss indoor visits in a facility that's currently in an outbreak situation. And in that instance, they say the resident and the visitor should wear a mask if tolerated and physically distance if possible during those visits. Elevator restrictions are no longer in place. And then live vocal performances, there's no longer a stipulation on the number of people who could perform. However, they do need to keep in mind if those community transmission levels are high, they'll need to wear masks while in the facility, just like everyone else. And then, another thing that Dr. Counard had touched on this as well, but viruses, oh my. And with this, again, it's just a reminder. We've reminded facilities. We'd like to remind everybody, COVID is not the only thing circulating out there. We're seeing an increase in flu cases. And so, we remind facilities that, look, if you have someone who has signs and symptoms, maybe it's best to go ahead and test for COVID-19 and influenza, just to be on the safe side. And this comes into play for others entering the facility and for family members and loved ones who want to come in to see their loved ones. They need to consider this as well, because maybe they feel a little crummy, got a little congestion, a little achy. They take a COVID-19 test, it's negative, and they think they're okay to go in to the facility and visit. But it may be influenza, it may be another respiratory virus. We've seen adult cases of RSV occurring. So we want to be mindful of these other viruses as well. We want to do our best to prevent from entering these facilities also. And I think that's all that I have, just other than the resource page for where a lot of this came. Again, I thank you guys for inviting me to come and speak today, and I hope that some of this information was useful to you. Thank you.
Oh, Mike, it was so useful. It was really, really important information that both you and Dr. Counard shared. We appreciate it so much because there are so many questions out there. I don't know if anybody does have a question. I don't know what your availability is. I don't know if you have to jump or not. But if there are some questions, if anybody would feel free, you could either raise your hand or you could put it in the chat, whichever way you would like. I did have a quick question. When is A lot of people were sent these tests. We received these tests in the mail quite a while ago. And if you look at them, they have expired, they're expired. What should I do about that?
Well, if they're expired, they wouldn't be considered good for you. Some test kits have had a date that's extended. There should be a way to look that up, but I'm not as familiar with that but let me see if I can get you that link where you could look up and see if there's been an extension on the particular test that you have.
Okay, yeah, just because I do know there's some family members, that might be testing before they go in.
Yeah.
And we want to make sure that this is being done properly, so that, especially
Test
during the
before you
holidays.
go. Definitely test before you go.
Yeah, because that's what this is all about, is staying safe during the holidays. I know personally, my family, we had to cancel Christmas 2 years in a row. So we're looking forward to being able to all be together now, and everyone's being very diligent right now so that we don't have to cancel Christmas again. And everyone's taking that into really serious right now, because we miss being together at the during the holidays. So again, I just want to thank you so much for being here today. We so appreciate whenever you guys can be here, because you are just such a wealth of information for us. So thank you for that. I'm not seeing any questions come through. Stephen, did you see any questions come through? I just have another. Okay. I have another question. Can you get COVID and the flu at the same time?
The infections, unfortunately, yes, you can. It's
Okay.
not very common that, this is the first year where we're really seeing flu activity with COVID. So who knows what the year will show. And we are seeing a lot of flu activity out in the community. It's a very steep increase, much earlier than usual. So please take every precaution to protect yourself against respiratory illnesses with masks that Mike was talking about, and making sure you get your vaccinations. But yes, you can get both of those conditions at the same time. We have had some people with both. It hasn't been very many that we're aware of yet, but I don't know what the future holds.
Thank you. And then just one more question, because this may impact people. What do I do if I can't get that? My doctor is not giving me an order to be able to get any of those treatments that you shared.
I don't know. Go to his office and throw a temper tantrum. I'm really not sure. It is frustrating that really there is a very low threshold. These medications have a great safety profile. As long as you don't have another medication you're taking that interacts with Paxlovid. So, there's not really much of a downside here, and it could be preventing you from having a much more severe illness. So definitely just be adamant that you should be getting the treatment that you deserve.
Good. And I think that that's the message that we always try to share during these resident family support councils, is to be your own advocate. And, to be that consumer and be that educated consumer. We did have this infection prevention team did do a session for us once on the various treatments that exist out there. So we have the YouTube of that, so that you can go ahead and you can reference that on our YouTube page as well. And that's just IL Ombudsman. It's just IL Ombudsman is the channel that we have. So we really, if you have more information, more questions about that, you can reference that. With that being said, it is 4 o'clock. So I'm going to go ahead and I'm going to stop recording right now. And I just want to publicly thank you guys so much for everything that you've done.